Hey everyone, this is Group 5 presenting on our ICF integrative case. I am Lyndon Dice, and with me are Emily Hart, Christy Ledden, Megan Leftwich, Claire LaHaye, and Aaron McClure. Here is the outline for our presentation. We will start with the objectives, which are next. By the end of the presentation, the viewer will be able to meet all of these objectives, which are listed below. We will give you a few seconds to view them. Everyone meet our patient. His name is Shane. He is a little boy who's 3 years old. His mom is his primary caregiver. He has a right transtibial amputation with an additional diagnosis of fibular hemiamelia. His anticipated length of stay is 1 week with a transition to home health and outpatient rehab. His activities are he enjoys playing with his sister, cartoons on TV, and baseball. And his MD orders are out of bed as tolerated.
Throughout this process, Shane will interact with many members of the healthcare team. He will attend physical therapy for strengthening and functional goals, occupational therapy for more self-care skills, surgeon to keep up with the surgical site and any post-surgical implications, his primary care pediatrician to ensure that he is medically stable and monitor his growth since he's only 3 years old, the prosthetist for shaping the limb and choosing a prosthesis, nursing for the care in the inpatient setting, a case management that can work with Shane's family about discharge planning, along with a psychologist that can talk with Shane and his family about his limb loss, social work services for financial and educational resources, and a dietitian since Shane is a picky eater and with his amputation it might take more energy for him to do activities.
Some of the positive factors that will affect Shane are his age, his adaptability, and his no attachment to his limb. Since he is young, he's still learning how to do a lot of his functional daily activities, so his prosthesis will be incorporated into his learning. This also goes to effect with his adaptability of other situations. Some of the negative factors are a negative body image, which it doesn't look normal for a 3-year-old, and he does not have private insurance, so Medicaid will be paying for his prosthesis, and they may not cover the highest functioning level that he could achieve, such as progressing to a K4. There's also parental guilt and possible custody issues. Since his parents are divorced, this could place a burden on the consistency in his treatment. Some of the important questions to ask in the patient interview are his history of amputation, his home environment, what kind of factors he's going to have to deal with at home, whether he's going to have a lot of stairs to climb, different things like that, his mode of ambulation, his need for other adaptive equipment, the age of his sister, complications following surgery, his pain level at the time and what causes it to get any worse, how his sleep is, and maintain limitations and adaptations, any further surgeries recommended by the doctor, and major goals for therapy.
Okay, so looking at our tests and measures, we checked out the vitals first, so heart rate, blood pressure, respiratory rate, and auscultation since he has had surgery for his limb. We will want to check the residual limb length and compare edema with the intact limb because prolonged edema can prolong pain, healing, and prosthetic fitting due to lack of proper shaping. We want to check the integumentary of the residual limb to track signs of infection. Healing status, we want to look at if the incision is healing, draining any dehiscence, if the sutures are in or out to check for, again, infection. For the condition of the limb, there's edema. Is it conical? Is it firm? Is the skin clear? We want to check his sensory integrity and check for proprioception since we don't know the exact cause of his amputation, and also when he gets fit with a prosthetic device, then we will want to be able to know if he can feel it or not. We want to assess range of motion, so right knee and hip range of motion and compare to the left side. We will also want to see his natural sitting and laying position to determine if he is at risk for contractures. For manual muscle tests, we'll want to check knee flexors, extensors, hip flexors, hip extensors, hip abduction, and hip adduction of the residual limb, which will be deferred until the limb has fully healed without any signs of infections. The same motions will be assessed for the intact limb as well as ankle motions to ensure normalized gait. So then for mobility, we will have bed mobility and transfers to wheelchair or out of bed to assistive device, wheelchair mobility if he has one, weight bearing for when he stands up, and gait analysis. Some of these will be deferred until after the prosthetic fitting, like gait analysis. Finally, balance and coordination is crucial for prosthesis wearers since he will have to don and doff his device. Okay, for the Medicare functional classification level, we put him at K3, and this will give him the ability to traverse most environmental barriers and will allow for prosthetic utilization beyond simple locomotion, such as for running and jumping. Since he is 3, he'll be able to, run around like kids do. And later on, we hope to progress him to K4 as he ages and is more functional.
So for the outcome measures for Shane, we have a few that we want to do. Some will have to wait until he either has the prosthetic and has gotten used to it, or until he's old enough to understand the wording on some of the questionnaires. So most of them will focus on functional components rather than the questionnaires because he is 3 years old right now. He might not understand the questionnaires that are asked, so we can either ask his mom or defer them until later on. So these are just some of the outcome measures that we decided to use. Some of the ones that will be deferred until he has a prosthetic are the tug, the 2-minute walk test, and the locomotor index. Here's our ICF problem list for Shane. His primary diagnosis was the right transtibial amputation, with his secondary diagnosis being a fibular hemimelia. So for the body structure function impairments, he's having right limb phantom limb sensation on that side. He has hamstring tightness bilaterally, right hip and knee muscular strength delay. He cannot balance on his single limb right now, and he has some pain while sleeping on his right side. He does have a little bit of swelling in his residual limb, and he has difficulty with postural control and sitting. Some activity impairments he has is difficulty standing to watch cartoons on the TV. He can't throw a ball when he's standing up. He has a hard time with bed mobility right now and transfers just because he's not used to his residual limb yet, so that's something we're going to have to address quickly. He has difficulty with lower extremity dressing just because of that balance impairment. And then he also has difficulty with showering and toileting. Some participation restrictions he has is he's unable to play baseball with his friends, and he has difficulty playing with his sister. He does live with his sister and his mother, and he's on Medicaid, so there may be some type of financial limitations there. His house is a 1,200 square foot house with 4 stairs into the house, so it's important that we address stair ambulation for him while we are working on that.
Now we're going to go over a recommendation for the prosthetic components for Shane. So overall, the socket design needs to account for differences in pressure tolerance and strength of the residual bone since he is a child. First off, we're going to utilize a gel liner to enhance the prosthetic's ability to fit deformed or scarred residual limbs. This is really important for him since he did have a congenital limb loss, so it increases the likelihood that it could be deformed or have scarred residual limb. It will also protect more sensitive tissues. We need to ensure that Shane and his family is educated on the importance of cleaning this gel liner to avoid the skin breakdown. Apart from the gel liner, we're also going to suggest a 3 to 5 ply sock, depending on the fit in the room between the gel liner and the prosthesis, since he will be growing very quickly as a 3-year-old. As far as suspension, we want to avoid the mount pistoning. We want to ensure and to ensure skin protection, we're going to suggest a pin and lock system. This system has a very simple design and also has an auditory click, so Shane can learn to use this system independently, even though with practice he is at a young age. So moving further down, we're going to suggest that Shane has an endoskeleton, since the socket of this endoskeleton can be interchangeable. There's also simple and fast maintenance with these, and they're very easily adjustable, which, as we've mentioned several times, is really important since he's a growing 3-year-old. So for the ankle component for Shane, we're going to suggest a dynamic response non-articulated segment. This has less moving parts since it's going to need to be adapted as he grows, but it will still provide him the means to be an active 3-year-old and provide him with a more normal gait. Just other considerations for him We're likely going to leave it cosmetically unfinished for the frequent alignment. We're also, overall, we want it to be comfortable, durable, to promote the compliance for him and prevent the skin breakdown and allow him to do his functional activities, such as playing with his sister and other things 3-year-olds do. Shane's prognosis for physical therapy is good to meet all physical therapy goals. He's a vibrant 3-year-old who enjoys playing with his sister and playing baseball. His incision is healed nicely with no signs or symptoms of infection, which is a positive factor for succeeding in physical therapy. The patient would benefit from physical therapy interventions like strengthening the residual limb muscles, education for both him and his family, and referral for a wheelchair or any other assistive walking devices. If he's not already using them, referral to a prosthetist, mirror therapy for phantom limb sensation and desensitization. Shane is to be seen in an inpatient clinic for 5 visits for 1 week. Each of these sessions will be 1 hour. At the end of the week, the patient will be reevaluated for discharge to home, which is their goal, and an assessment of status pertaining to the goals, as well as goal progression, will be performed. From home, he'll be transitioned to an outpatient rehab facility to be seen twice a week for an hour for 12 weeks. And at this time, we'll determine if physical therapy is an effective strategy for Shane or if interventions need to be modified, or how long and adjust the plan of care accordingly.
So with Shane, he is in an inpatient setting and we plan to have him home in 1 week. So some of our short-term goals, they're over 3 days, and by the end of that time, we want him to be independent in bed mobility, so that he can get from supine to side lying to prone in order to decrease any risk that he may have of DVT and to decrease his chance of hip contractures. We also want him to be able to perform desensitization exercises independently to decrease phantom limb sensation. And lastly, perform sitting balance for 2 minutes by throwing a balloon back and forth to the caregiver and PT. This will help him when he's trying to don and doff his prosthesis and different activities like that during the day. After 1 week, we want him to be independent with transfers, including chair to mat, mat to chair, and supine to sit to facilitate independence at home, and also this will help with that donning and doffing of the prosthesis. We want him to be able to wrap his residual limb independently with less than 1 verbal cue from the therapist, and that's just going to help with his hygiene of his limb and just making sure that it stays in that shape. And if he learns this early on, it's going to be easier as he gets older, because this is something that he's always going to have to deal with. Also, for the last goal, we want him to be able to stand for 2 minutes with only using 1 upper extremity for support to facilitate things such as brushing his hair, brushing his teeth, anything that really requires 1 arm to do, that he can still have a little bit of balance, but we want him to be able to be functional when we discharge him.
Interventions will begin with residual limb care. Shane's parents will be highly involved in this process, but he will also need to be made aware of the importance of this and how to properly care for his residual limb. We'll focus on proper wrapping of the residual limb and educations of signs of infection, as well as proper shaping of the residual limb. This can also be done on a doll to make it more interactive for Shane. Next, we will also focus on balance and stability. We will perform activities like single leg stance on the intact limb and other static balance activities. We will do reaching, stability, and balance by having the PT hold an object within reachable distance of the patient, and the patient will reach for the object. Since he is young, we can use rings being placed on a dowel to keep him interested for longer. We can then transition to tapping a balloon back and forth with the PT or his mother. We will also practice stepping up with the intact leg to practice balance and stability on his prosthesis. We can start within parallel bars and then transition to actual stairs. We will also practice standing on the prosthetic leg while moving a ball around with his intact leg. Vice versa will be used for prosthetic and residual limb control more so than stability. Balance will be key to Shane's recovery, as it is key to his safety. We will also perform range of motion. This will be especially important to prevent flexion contractures. Interventions will include placing Shane in supine and pressing his knee into the table or the ground to gain extension and holding for 30 seconds. To keep him in this position, we can lay him down and have him pressing a soft toy under his knee. We can also perform prone hip flexor stretches for about 30-second holds and do this by having him lie on his stomach and watch YouTube videos. Strengthening for Shane will include kicking a ball tossed at him while he's sitting on the edge of a mat table to work on his sitting balance and used to don and doff his prosthesis, and on quadricep strength that he will need to ambulate. We can practice hip extension with Shane in prone by cueing the patient to fly like Superman and hold this position for 10 seconds at a time in order to save the world. For straight leg raises in supine, we will have a TheraBand around his ankle and a prosthesis and have him kick the ball outside with the outside of his foot into bowling pins. We'll repeat this activity on both sides until all the pins are knocked down 2 times. For bridging, we can sing London Bridges while rolling a ball under him. We'll try to complete 5 rolls 3 times. Another activity for Shane is jumping on a mini trampoline while holding onto the rail. We can have him count as he bounces. Strength training of both the residual and intact limb will be important to ensure he has adequate strength to walk and return to his daily activities with minimal risk of falling. We'll also need to educate Shane on how to fall with minimal risks. We can do this by playing Ring Around the Rosie. He'll sing and dance in a circle to work on his balance and then fall down in a safe manner to teach him the importance of falling down safely. He will likely fall with his knee prosthetic, so it is important to go ahead and teach him how to fall safely onto a mat. Next, we will work on functional movements. This includes sitting on the floor, getting up from the floor, sit to stands, bending over to pick an object up off the floor, and kneeling. For sitting on the floor, Shane will place his prosthetic foot behind his intact foot with his weight over his intact foot. He will then bend from the waist and flex at the knees and hips to reach for the floor with both arms outstretched. At this time, he will pivot towards the intact side and gradually lower his body to the floor in one continuous motion. To get up from the floor, as if he were to fall, he will need to transition to his hands and knees, then place his intact leg forward under his trunk. The intact foot should be flat on the floor while he balances on his prosthetic knee and his hands. Then extend the sound knee while maintaining his base of support on the intact leg. He can push through his hands and intact leg to stand erect and then move his prosthetic forward. For sit to stands, he will need adequate strength in his lower extremities, as well as balance to complete this functional task as if he was rising from a chair or toilet. We can start Shane at a higher surface and progress to lower surfaces without any use of his upper extremities. To bend forward and pick an object off the floor, Shane should put his intact leg in front of his prosthetic and shift his weight forward onto his intact leg. From here, he will bend forward at the waist and flex at the hips and knees until he can reach the object on the ground. Shane should also practice picking up objects on the ground by his good side, as some patients prefer side bending and keeping the prosthetic leg straight this way as opposed to picking up an object in front of them. For kneeling, Shane will place his intact foot out in front, keeping most of his weight over his intact leg. He will then shift his weight forward by flexing at the trunk, hips, and knees until he can place his new prosthetic leg on the floor. He will then get up the same way he would from the floor as previously stated. Proprioceptive training will take place in conjunction with gait training. To practice proprioception, we'll perform a star drill or clock training. We'll have Shane stand on a numbered clock or star surface, then the PT will call out a number and he will have to accurately shift his weight to reach the respective number with his prosthesis. This will train him to know where the prosthetic is in space. To progress this, the numbers can go farther away, so he has to reach farther, and the PT can also increase the speed.
Another intervention that Shane will participate in will be gait training. Shane will start with stepping forward and back in place within parallel bars and then progress to freestanding. We will try to make a game of it since Shane is a 3-year-old. Shane will perform this first with the prosthesis in motion, then he will work on weight bearing through the prosthesis while moving the intact limb. We may try to have Shane reach for a toy and then also just try to take those single steps first in place, then work to taking those steps 2 and then step through by putting the toy out farther in front of him. We'll also work on stepping backward and with the prosthesis and also the unaffected limb. Shane will then progress to clearing objects, which includes facing an obstacle, which could be a step or a small cone, and placing the sound foot or unaffected limb over the obstacle and transferring body weight from the prosthetic to the sound leg, and then moving the prosthetic over the obstacle. You can also do this sideways, sidestepping over the object as well. The next intervention would be doll therapy. This has been found to be very effective for children. It is an individualized therapy using a doll with features resembling the child, including hair and eye color, sex, race, and age. The doll is adapted so that he has an amputation at the same level, as well as a prosthesis that looks very similar to the prosthetic the child will have. The child can use this doll in therapy to practice donning and doffing the prosthesis and is encouraged to bring the doll to all clinical appointments. They can use the doll to practice positioning, changing the prosthesis, doing some of the exercises they might be doing. It helps kind of get them to interact a little more and participate. And it is recommended that the doll be introduced to the child during inpatient, but can also be introduced during outpatient rehab. Lastly, mirror therapy has been proven to be effective for those with lower limb amputations. We would attempt to have Shane perform movements with the amputated limb while watching the reflection of the intact limb in the mirror, and the amount of time only needs to be 15 minutes to have a decrease in the intensity of pain and the frequency of pain that is experienced.
Okay, so now finally we have the discharge plan. So Shane will go to the prosthetist pretty frequently. Since he's only 3 years old, he will be visiting to make changes in the prosthesis or liners and learn how to don and doff the prosthesis. Since he'll be using a gel liner and maybe playing in sandboxes or dirt, it's important to teach him and his mom how to clean the liners to prevent infections or skin breakdown. Also, as he becomes more active, he will hopefully progress from a K3 prosthesis to a K4. He'll go to physical therapy twice a week for an hour for balance training and bed mobility and mobility around the house, as well as the interventions that we mentioned before. He may need to go to a mental health professional just for adjustment to a prosthetic can be difficult. So it's likely that Shane and potentially his parents will benefit from the help of a mental health professional to adjust to the change. He's young, so he may not fully understand the change, but he will likely adapt well. He may need to go to social work services. Communication with social services will help the family move forward together and adjust their lifestyle to Shane's needs. They can more easily find support groups and stay integrated with other families with similar situations. And finally, he'll need to go to a dietitian more than likely because it's important for him to consume adequate calcium, vitamin D, and other nutrients essential to bone growth. Whether it be through food or supplements, his bones will develop at a slower rate due to decreased weight bearing until he has a prosthetic device and until he returns to play and sport.